again, there are some group of patients that will not survive intubation, especially immunocompromised patients. We know their immune system is so weak, and now we are bypassing, our natural defenses to prevent any pneumonia or any other complications with the intubation. We know it's going to be an issue.
I gotta go. I've been working, told them please don't hit my phone. I'm in my zone, bruh, just leave me alone. Was on the road, but I swear I'm coming home. Now the drinks on me, I think we need a toast. See, I did it for me. Now my old friends calling, told them nothing's for free. Told me time is money, dog, swear I paid all my fees. I was starving for this game, now my family can eat.
Hey everyone, welcome to the Cup of Nurses show, here with your hosts, Peter and Matt, two nurses on a mission to change this world, one conversation at a time. If you find value on this show and want to join us on this mission, please share and review the show. It would mean absolutely everything to us. For our latest info and updates, you can check out cupofnurses.com. And for our lifestyle podcast, you can check out wearefrontlinewarriors.com. Brief announcement, it is December, Christmas time. If you want to get some hot nursing merch, maybe for somebody that you know or for yourself, the cupofnurses.shop has 15% off on all sales if you use the code MERRY15. That's MERRY 15. Peter and I are wearing some Cup of Nurses merch right now. It is hot. Get it while supplies last.
It's hot. Merch is hot, but the winter's cold. In this episode, we'd like to introduce you to Aurika Savickaite. Aurika has worked as a registered nurse and patient care manager at the University of Chicago Medical Center's Medical Intensive Care Unit. Aurika was involved in a successful testing of the helmet ventilator in the ICU at the University of Chicago during a 3-year trial study. In this episode, we focus on the benefits of helmet-based, non-invasive, positive pressure ventilation on patient outcomes. Thank you, Aurika, for being here. Can you give us a little bit of a background about yourself and how you guys started in this project?
Yes, well, thank you, Matt and Peter, for having me here. I'm very excited to share my story and my mission. And I know we're here to change the world, right? So my mission is very much about changing the world in our ICU units, in our ER departments, how we treat patients and how we can actually save more lives by using non-invasive ventilation more often. And I'm originally from Lithuania, so I got my bachelor's degree in nursing back in Vilnius, and I did work as a registered nurse in an ICU in Lithuania. When I came to US, I worked as a registered nurse at University of Chicago hospitals. And that was back in 2005. Then in 2010, I got promoted to be a patient care manager for the medical ICU that I worked. And it was very interesting and challenging move that I did in my life, in my career. And at the same time, I also decided to pursue my Master of Science in Nursing, an acute care nurse practitioner degree at Rush University College of Nursing. So a lot of things were happening back then. And also in 2014, when I was completing my master's degree, Dr. Patel and her team did a study in a medical ICU at University of Chicago with helmet interfaces. They actually had patients, immunocompromised patients, who used helmet interface to receive positive pressure ventilation or to use a face mask. So during that time, I actually saw patients on the helmet interface, and I decided to write my capstone paper actually about patient who was in ARDS, used the helmet, and actually survived the stay in the ICU.
Wow. Yeah, can you give us a little more information about the helmet? How is the helmet different from like typical like face mask? How does it look like? What do people expect to see if you bring the helmet?
Yeah, so first, when I saw the helmet, actually, I look at this device and, in ICU, we have so many cool gadgets, very high tech with all the buttons and numbers, right? And I saw this helmet in the unit and I was thinking, what the heck is this? It's kind of bulky, simple, device that looks like a hood. So it is actually a clear plastic hood that goes over the patient's head and connects to the collar, okay? That goes, that has a nice soft seal around the neck. So what happens when this hood, so just imagine like you would go to space, right? You have this hood, but this is a plastic one that is inflated. So it inflates in a second. So with this device, or we call it interface, it's the same like face mask. It is just one of the types of interfaces. Nothing is touching patient's face, and he has unobstructed view because of the plastic hood, right? And the seal is created not around the patient's face, mouth, and nose that we usually see with the face mask, but the seal is actually created around the patient's neck. And just because, necks come in maybe different sizes, but the same shape, it's much easier to create that good seal around the neck than the face. And the nurses who work in ICU settings or step-down units where we use face masks a lot, we know how sometimes it's hard to create that seal around the face mask so there are no air leaks to actually keep that positive pressure in the system, right? So this is how the helmet looks. And of course, you're gonna need two inlet and outlet ports where the air is coming in and coming out. Also, there is a patient access port, which is so easy to use. And even some patients can use it by themselves. If they need to take a sip of water or suction their mouth, they can easily access their face through the special opening. And it depends on what type of helmet are you using. We have different ways to access patient face without actually interrupting the therapy itself. So those main parts of the helmet. Another very important part is actually underarm straps. So what happens when the helmet gets inflated because of that positive pressure in the helmet? It starts to rise up like a balloon. And to keep that helmet down, and that helps actually to keep that seal intact around the neck, you have underarm straps. So those are usually just the soft straps that keep the helmet down and improve the therapy, non-invasive positive pressure ventilation therapy.
It sounds very fascinating.
Yeah, go ahead.
One issue that we have with, for example, BiPAP face masks is the interruption of therapy. You got to give somebody PO meds, their mouth dries up, they get thirsty. So you're always switching between BiPAP or the nasal cannula. Then they desat. All right, sweetie, we got to put the mask back on. You're satting 85%, slap it back on. So there's a lot of that like interruption that could prevent the healing process. And then also you mentioned that it's not going on the face and there's no air leaks. So a lot of times we get the fatigue from the ventilators, especially if they have like different facial structures and they're leaking above like, I don't even know what the number is, but 50 or 40 or 60, those numbers where you're just like, all right, we have to tweak the alarms and call respiratory because this is happening. Yeah. And then the injury part of things, right? There's always injuries that are happening. We're trying to put plastic on their nose to prevent the skin breakdown of having long-term positive ventilation.
Yes, and you mentioned very important, complications that happen with the patients. And usually we don't see what happened next with these patients, but they go through a lot of, procedures and even surgeries if you get necrosis on the face from the use of face mask. And Also, another thing that I learned recently, there was a study done where we looked at the vocal cord edema and we compared the face mask and the helmet patients. And we saw that vocal cord edema was 73% in face mask group and only 7% in helmet group. So also like laryngeal bleeding ulceration and hyperemia. So this is where when we mention all these complications, we're actually talking about patient comfort. And as you know, the main reason, one of the top reasons why the non-invasive ventilation fails is the comfort issue. The interface doesn't fit the patient. And like you said, patient face can be different. And also, especially in older ones who have that, less padding on their face, it's less, or they have missing teeth. With the helmet, you don't have to worry about it. So it's kind of universal fit when you use helmet interface. You don't have to worry about the facial hair. You don't have to worry about even trauma to the face. There was one case where we used helmet for patient post sinus surgeries. And it worked just fine. We didn't need to intubate that patient. Another thing is important for patients in a helmet, we can have their glasses on. And, we don't think about that very much, but actually when you are there and you are sick, the ability to see well is very important, and it makes you feel, more like a human being, right? So yeah, absolutely. You mentioned very important, features that helmet can help with.
And just to kind of take a step back, just so everybody that's listening understands the reason of putting positive ventilation, can you briefly just describe the reason why we do positive pressure ventilation for patients and the anatomy effects of instilling the positive ventilation?
Yeah, so non-invasive positive pressure ventilation involves the delivery of oxygen into the lungs thanks to the positive pressure without putting the endotracheal intubation. And you probably heard about its use for patients in a sleep apnea that we're using at home, the cpap. And there are, in a hospital, we usually use for the type 1 respiratory distress, where the alveoli are flooded by the fluid caused by pneumonia or emphysema. And what happens then, we have issues with the gas exchange. And when we apply this positive pressure ventilation, we are able to open up those alveoli and improve the gas exchange and increase the oxygen therapy. And also we will be, can I answer this again?
Yeah, I'm just wondering what's
Sorry.
My question is what is like the positive effects of positive ventilation for like the anatomy of like the lungs, and how does it actually benefit the patient?
Right. Or why do we need non-invasive positive pressure ventilation? Like what's going on where the patient needs to be put on a CPAP, BiPAP, or this a helmet-based intervention?
Okay. I don't want to go too deep into it, so I'm trying, to. Okay. So, let me take a pause. So what is non-invasive positive pressure ventilation? It is actually delivering the oxygen into the lungs by applying positive pressure ventilation and without using invasive endotracheal intubation. And the reason why we need it is because sometimes just the oxygen therapy that we use, like nasal cannula or face mask, without the pressure is just not enough because due to the pneumonia or emphysema or ARDS, the alveoli in your lungs are inflamed. And what happens, we collapse. And when we are collapsed, these alveoli are not good for the gas exchange. So with this non-invasive positive pressure ventilation, we are able to open up those alveoli and help them to stay open. And at the same time, we will increase the gas exchange in those units. So, and there are two different ways to do it. So you can use a cpap therapy. This is when you just have the expiratory, positive and expiratory pressure applied. So what happens, the patient decides how deep the breath we want to take. But when we exhale, actually the pressure that is in the helmet will also stay in the patient's lungs. So that pressure will keep those alveoli open. And then there is another setting, the BiPAP or pressure support ventilation, where we actually helping to ventilate those alveoli, where we actually increasing that tidal volume by increasing the pressure at the time when patient is taking a breath in. So I hope I explained that, explained it in a short.
Yeah,
That was really good.
Yeah, it makes complete sense, because if you have collapsed alveoli, it's not able to produce that gas exchange, you're not able to oxygenate your blood and your organs, and we need that positive pressure to keep those alveoli opened and actually do what they're supposed to be doing, because if they're collapsed, they're not doing anything, you know.
And anybody that's not in the ICU setting listening is, of course, we could intubate a patient and deliver the best therapy and gas exchange, but there's a lot of complications with intubation, sedation, them not being able to get extubated, them developing pneumonia. So this is prevention medicine before taking that ultimate step and needing to be connected to life support.
Yeah, there's a reason why when we hear, hey, patient room 12 might get intubated, we're like, oh shit, might get intubated, because we literally try everything in our power to prevent intubation, because once they're intubated, they are really compromised. They're more prone to, like you said, pneumonia, more prone to sepsis. And once somebody gets on the ventilator, they're already in bad shape. And their chances of coming off a mechanical ventilator are really low in theory. You know, that's why we don't want to intubate people, is because then trying to get them off the ventilator, weaning them off, it's a really, really long process, and not everybody could come off. People get trachs, they're forever trach then, you know, it's damage to the vocal cords. It's a really big problem when somebody becomes intubated, because the chances of them coming off the ventilator are not the greatest. That's why we want to instill any kind of actions or any kind of protocols or any kind of interventions to prevent them from being intubated. Because once they're intubated, they're not in a really big, or they're not really in a good spot. So how does the helmet-based interface differ, and how is it better than our typical BiPAP and CPAP on like the number standpoint? Does it prevent less intubations? How do the numbers look like?
Yeah, so I will go back to the study that Dr. Patel did at University of Chicago. And actually that was the first study done in US. But helmet interface has been used in Italy for over 20 years. Oh. And to what you just said earlier, I want to add one more very important thing, is that with non-invasive ventilation, you're actually saving resources too. You know, it's the ventilator, is all the sedatives that you're using, all the other medication that you will need to use for the complications that are happening with invasive ventilation. So, and again, there are some group of patients that will not survive intubation, like especially immunocompromised patients. We know their immune system is so weak, and now we are bypassing, you know, our natural defenses to prevent any pneumonia or any other complications with the intubation. We know it's going to be an issue. So what we found at the University of Chicago during the study that was actually published in 2016 in JAMA, that intubation rate for the helmet patient was 18% versus face masks 62%.
Wow.
And at the same time, mortality was much lower for the patients. It was 27% for helmet group and 49% for the face mask.
Mm-hmm.
And also the 90-day mortality was much lower in the helmet group, 34 versus 56%. And what was interesting that this study, they end up completing sooner than expected. Just because when we put the first data in, it became unethical to use a face mask for these patients because we saw such a big advantage of helmet interface. So it's also an interesting, fact that we were able to publish the study much sooner because it showed such a great benefits of helmet interface and how superior it was to the face mask.
Mm-hmm.
So now, I was just gonna say, so now University of Chicago, where this therapy started, did we completely remove face masks then, and we're just using helmet intervention?
So you cannot remove face masks, and there is a reason why, because sometimes you will use non-invasive ventilation for a very short period of time, and sometimes maybe it's easier just to put the face mask on. But for patients who you believe will need that non-invasive ventilation for more than 8-12 hours, where you see that there will be some issue with the air leaks, or let's say you will need to apply a higher PEEP, that's where the helmet needs to be applied.
Okay.
If when I talk with Italian experts who are using helmets for, like I said, over 20 years now, we still use face masks. So again, we're not replacing completely other interfaces that are out there. It just we adding another tool in our toolbox in our supply room. And now when we have a patient who needs non-invasive ventilation, we can fit the interface for that patient, not vice versa. And that makes not just the patient's stay and outcomes better, but also it helps nurses and physicians and respiratory therapists to work with patients who have less complications and better comfort with non-invasive ventilation.
And if a patient is wearing this helmet, do you have to turn it off for them to maybe take their pills or drink water? It has to get turned off, right? Same concept.
So there's you don't have to turn it off completely. So it's continuous airflow, and there is patient access ports. So some are big enough where you can fit through that port your hand and just give them the pills. You open up, so definitely when you open the port, the pressure will drop, but you still have oxygen running. So it's like putting in a nasal cannula or something. You still have oxygen in the helmet. It just the pressure will drop because you opened the patient access port.
Yeah.
But it takes you literally seconds to get that pressure back on because you're not taking the helmet off. You still keep the patient, the helmet on the patient. You open the patient access port, do what you have to do, like provide the oral care section, give the pills, give a sip of water. And the moment you close it, it's inflated in a second. So that's why the interruptions are down to minimum when you use a helmet interface. And again, with PEEP that you can apply, such a higher PEEP for helmet patients can help them to extend that bridge that we say, because with non-invasive ventilation, what do? We're giving them more time so the other therapies start to work and patients start to heal, right?
Yeah.
So that's what we are doing. We're giving them more time. That's kind of bridge to the next level. And that next level can be intubation or actually going down on a nasal cannula, right? So with this helmet, what you do, you actually give them more time to get better. Or actually you will see usually it takes about 2 hours or even less, where you will see that helmet is not working and you need to intubate. So again, very important thing, helmet is not replacing the mechanical ventilation. And delaying intubation, we know it's going to be worse outcomes for the patient. So again, don't use a helmet as a last resort.
Mhm.
Helmet should be used the moment you see order that patient needs to have a CPAP therapy or a BiPAP therapy, because helmet is an interface that should fit the patient perfectly. And there is no magic, nothing magic about the helmet. I want to say that too. It just, you want to be aware that this kind of device exists, and this will fit probably most of your patients, especially older patients, or, patients even who have claustrophobia, believe it or not. With the helmet, the cases of claustrophobia is less than 1%, where with the face mask is very high.
That's a very good point, because that's something I wanted to ask next. So, in my clinical experience, there's a lot of anxiety associated with using BiPAP. They want to tear it apart, take it off continuously. We restrain these patients sometimes. We're pushing Ativan to help with their anxiety, and that just leads to more complications. They get more tachypnic and probably just pushes them towards that endotracheal intubation a lot more. So, was there any research comparing the amount of medications you're using for regular face mask interfaces versus the helmet therapies, as far as maybe Ativan or needing restraints and etc.?
So there are, and there are many studies from Italy. I will mention actually pediatric population, where they also using helmet, and we usually use helmet CPAP. So all these kids and babies that use helmet usually don't have any sedation or any pain medication received. They don't receive any pain medication, where with the face mask they will be. So there are like many studies that mention that. For adults, we did use some meds at University of Chicago, and that's because we also did deliver bi-level ventilation for these patients. So you imagine this is a little bit harder therapy for the patient to take, because when you're inhaling, you get this push of air to increase the ventilation, right? To ventilate the lung. Where with the CPAP, there's nothing like that. With CPAP, it's kind of gentle ventilation and more comfortable for the patient. So again, it depends on what therapy you're using. And some patients will have a sedation during the helmet non-invasive ventilation. And there is very good study by Greco and colleagues from Italy who compared high flow nasal cannula and helmet non-invasive ventilation. So again, when I say helmet non-invasive ventilation, that means it is bi-level ventilation, pressure support ventilation or BiPAP, okay? So those patients are usually much sicker. They have PCO2 much higher, so they need to ventilate their lungs more aggressively. So these patients, what happened, they had higher, so the helmet patients had some sedation, where the high flow nasal cannula obviously didn't, because again, high flow nasal cannula is it's a very comfortable interface. But we did have actually less intubation rate in the helmet patients. So again, now when we think that high flow nasal cannula patients and helmet patients who received sedation, we still did better, right? Because we didn't get intubated. The study actually found that the length of hospitalization for these both groups were not different. So that's one thing. But the intubation rate actually was that was an interesting finding, that we had much less in the patient in the helmet. Yeah, so there are many studies coming out now, especially the ones that were done with COVID patients. So again, Italy used helmet for COVID patients, and they even because we are making helmets too in Italy. There are 3 companies who are making helmets. So the government prohibited to export any helmets during the 2020 COVID pandemic. And that's why a lot of countries around the world started to make their own helmets, and including US.
Yeah. How's the noise of the helmets? Because if it goes over your head, right, you're surrounded by this, are you constantly hearing air? Because in BiPAPs and CPAPs, you're just covering the mouth and the nose for the most part, so it doesn't affect your hearing at all unless it's alarming. So with these helmets, does it affect their hearing? Do you have to speak louder to these patients to get them to understand?
Yeah, very good question. And noise can be an issue, but it's important to understand that helmet is not making the noise. It just amplifies the noise. So it depends what kind of therapy, what kind of machine are you connecting to the helmet. If it's a bi-level ventilation, it's usually not noisy because of the ventilator, and also by using correct tubing that is connected to the helmet. It's usually a corrugated tubing, smooth bore, so it doesn't create that turbulence in the tubing. Automatically, it's going to be less noisy in a helmet. If you use helmet without the ventilator, which is, again, another great feature that you can save resources in helmets, and ventilators, is that with the helmet, you can just connect it to the wall gases, and you will have a CPAP therapy for this patient right now, right there, without any machine connected. But this is a noisy setup. This is going to be noisy. So usually patients, we have just the earplugs, or we put the filter on the air where the air enters the helmet, and that filter, the antibacterial filter that we use, on the ventilators, works like a muffler. So it actually reduces the noise in a helmet. What I noticed when I was at University of Chicago, that patients actually just fell asleep when we put the helmet on, because that noise was kind of like a white noise. And that was the first time we saw patients actually resting. When we put the helmet on, we usually just go to sleep, and we would worry, is it maybe CO2 rebreathing issue or something? But we finally got some rest, and finally we feel comfortable during non-invasive ventilation.
I'm about to put on my CWAP patients next time I get one. Put a little helmet on them with the white noise, get a little melatonin. They're good. No need for Ativan. Yeah.
So, I had a pleasure to go to New Zealand to one of the conferences there, and I talked with nurses. What are their experience with helmets? And we said, we love it. So people who are using, nurses especially, we say, we love it because patients so comfortable in it. And I heard from other experts that we use for patients who are compatible. I'm sorry. I also heard from other experts who use helmets for patients who are not cooperative. Let's say dementia patients, and who take the mask off all the time. So when you put the helmet on, it's going to stay on it, and it will be good also for the staff.
You mentioned the New Zealand study, because you already have these helmets in New Zealand, right? So how is that research looking from New Zealand? You mentioned a lot about the research done in Italy and their work with these helmets. How is New Zealand taking these helmets, and how are the results presenting in those hospitals?
So New Zealand is actually very new for helmets. The reason why we got helmets now is because of COVID pandemic. But in New Zealand, we have a lot of clinicians from United Kingdom. And UK is using helmets for a long time now. So what happened, a lot of physicians in New Zealand were able to apply helmets for the COVID patients.
Mm.
And during the conference, I met with many of them who are very excited that it's finally available in their hospitals. And again, they just have to go through that learning curve with the staff. So because we don't have respiratory therapists in New Zealand, nurses are doing all of that. So we have to set up the helmet and ventilator. So that's the main thing that we have to do, is actually convince their staff, teach them how to use it, and then, you know, practice on a daily basis, because this is how you can get good on it, right? So the same is in US also. Helmets are there available. Anyone can buy it. The problem is, are you ready to go through that learning curve? Because you have a big team that has to learn a new device. It is a simple device, but still there is a learning curve. And I still notice in the US, especially, there's a confusion about helmet and the studies that people read about helmets. Confusion is about terminology. Like I mentioned before, helmet NIV is the bi-level ventilation therapy. Helmet CPAP is the CPAP therapy. So a lot of studies that talk about helmet NIV, that means that we are talking about bi-level ventilation, and just people assume that it's also a CPAP therapy, but it's not. So you have to be very careful when you read these studies or when you use the terminology. So I learned that. Also in US, I learned that a lot of clinicians think that helmet will replace the ventilator, where again, that's not true. Helmet should not be used as a last resort. Helmet should be used the moment you see in your protocol that patient needs a CPAP or BiPAP therapy. This is when you think, okay, so which interface will fit that patient? So yeah, in New Zealand, I really like to chat with all the physicians, and I did a couple of presentations. And also we did a workshop where we just showed how it, you know, works on a volunteer. And I hope that a lot of those clinicians will come back to their units and actually try the helmet themselves first. That's also a very important thing, especially when we talk about patient anxiety and claustrophobia. If you are the person who's going to put that helmet on the patient, you want to be very confident and know what you're doing. So my advice, and not just mine, also Italians that I talked with, they say you have to try the helmet on yourself first. Because when the patient will ask you, yeah, so you did put that back on your head yourself, you wanted to answer, yes, I did, and it feels comfortable. So that's like one of my advices for the first-time users. You want to try it on yourself, and then you will know how it feels, and it's going to help you to stay confident and you know, make that stress-free transition from, let's say, face mask to the helmet for the patient.
I'm just curious on how is your team and you, how do you approach like the United States market, and would you pitch it to hospitals or organizations? What is like that approach? And I'm also selfishly asking because maybe I'll have an intervention in like a year or two. Peter and I'll invent something, who knows? But like, how do you actually go about introducing your product to a different like market in healthcare?
You know, it was easier due in 2020, beginning of 21, just because we still were fighting and we were not sure what we are doing with COVID patients. So definitely, you know, non-invasive ventilation was better than intubation. So that was easy for me to even go to the hospital and, you know, do the workshop and teach about the helmet. But the problem was we didn't have good helmets available because of the FDA approval. So, but now we have all these helmets, FDA, EUA approved, so hospitals can use it, but we have other issue. A lot of nurses and doctors are burned out. So anything that you want to bring new to the hospital now, we will say, stop it. We cannot take any new stuff anymore. And, it is a problem. And a lot of clinicians don't like the change.
Yeah.
And so it's a human factor that you have to go over, that you have to keep in mind when you talk about something new. And when I talk about helmets, my client is a nurse, a respiratory therapist, and a physician. So I want to tell them how the helmet can help them actually to have to save time and be more efficient on a unit.
Yeah, it's a big thing to bring up because every time I hear that, hey, there's somebody coming in, they're gonna show us a new product. It's like, damn, I gotta learn how to do something now that took me maybe like a few minutes to do because I've been doing it for the last 5 years. Now I have to try to do it a different way, which is then going to take up more time in the beginning, but then I know I'll eventually learn how to do it. But it's like getting over that hump of just devoting a little bit more time now so then you can improve patient outcomes more in the future. And like you mentioned, a lot of these places are understaffed and high workloads, real stressed, where it's hard for that physician or that nurse to take this extra step of devoting more time now to then seeing better results in the future. That's like the biggest block. That's the biggest block for us too. Like when I see an in-service coming, I'm like, man, I don't really want to do this in service.
Like the new dressings. You're like, oh, okay, now they're dressing. I already know how to do it this way. So.
Or those foam things for turning patients. Instead of a pillow, you use like that foam thing. You gotta mold it into the back where it's like instead of putting a pillow. But those foam things actually work really well. It's just in the beginning, it's just a pain in the butt to do because you're trying to figure out how to do it. You're not as efficient in it compared to the things that you've been doing for the last 5 years. Yeah. But is it better for the patient? Yeah. Do we feel like doing it? For some reason, it's no.
And that's a very good point that you guys both bring up. It's just we're overworked and overstressed as a healthcare collective, and there's no creative juices to try a new product for better outcomes because you're not worried about better outcomes. You're worried about like survival mode, trying to just get by in your workplace.
Yeah, and we're stuck in healthcare because we always want to improve patient satisfaction, improve patient outcomes, but we don't have that time for that change. So how do you expect to improve patient outcomes and have a better cohort on the unit if nothing's being changed? You're basically just hopelessly, or not hopelessly, but you're just instilling hope and hopefully something better happens. But nothing ever is going to improve if you're just doing the same thing over and over and over again. And to improve, you have to devote some time into doing something else, which then takes a little bit more time. But as like healthcare professionals, we have to realize that we can change healthcare, we can change patient outcomes if we're not doing something different, if we're not bringing in new technology, if we're not changing up our routine. If you don't change anything, how can you ever expect to have better outcomes or ever have any kind of impact on healthcare? You really can't.
Yeah, listen, I hear you. I remember days when I was a nurse in the unit and then a patient care manager. So you imagine I come to the unit and say, here, we have a new protocol or we have something new on our Epic charting. And, again, another thing that I learned during those years that sometimes something that is so high tech is not always better, because what I noticed on the unit, we started to become like alarm overwhelmed. I don't know if you feel the same, but we have so much technology and everything is just alarming and beeping that people start to ignore, and then something terrible happens. And at the same time, can you blame a person? No, you can't. And that's what that's my belief, that you cannot blame a person. There is something else. It's the system failure. So if we can bring something that maybe is not even so high tech, like for example, helmet, right? Something simple that's been here over 20 years. can actually improve and help us to do our work better and, to take a break from everything. So yeah, I like crazy things that I was thinking about when I was a patient care manager is like, even for the night shift, I strongly believe that we need to have at least 2-hour nap.
I love that. I love
Believe it or
that.
not as well. Believe it or not as well. 100%.
I was doing that in Lithuania in the ICU, and guess what? Nobody died.
Mm-hmm.
It was very well, organized schedule. We did have sometimes days where we couldn't take a nap during the night because it was just hectic, busy, and you just couldn't do it. But most of the time, I was able to get 2 hours sleep during the night.
That's why we're nurses in California, so we can get at least that 1 hour.
Yeah, at
Yeah,
least
yeah.
one. I heard that, like, if you can at least lay your head on a pillow around 1 a.m., you're already doing something good for your body.
Oh yeah. Like when I take a break, because usually I do labs like 3 or 4 o'clock in the morning. When I get the hour nap before labs, like those labs are getting drawn super quick. Like I'm a whole different person with that nap. Never If I get that nap, blood's not gonna hemolyze at all. I'm telling you, it doesn't happen.
That's a hack. You can hack that body but with 1 hour nap, and you perform at your best.
Yeah.
And it'd be pretty cool as a clinician, since we are like the front line and we see everything we don't need to look at research studies. We see the research happening day to day with our patients, and we're able to troubleshoot things. I would love to, as a nurse, be comfortable seeing how I can improve healthcare, how can I improve this situation, what can we do differently, and be empowered to do so. But I'm not even thinking about that one bit, because I got 30 tasks, I'm floating, and there's just way too much stress on a nurse themselves to improve healthcare. I'm sure as a profession, if we got together, felt empowered, we could make some positive changes, because we have people with a lot of money and nice suits implementing change, but we could probably do a better job at implementing it. We're just way too overworked, man. There's no creative juices to do so.
Yeah, facts. It's like the people that are leading this change in nursing and in patient care are the ones that deal least in nursing and with patient care. Right? And you're completely right. Like if you offer the workload for the nurses are going to be able to come up with better ideas on how to treat certain things. It's just that we don't have time for that because we're just overwhelmed with everything that we have to do. All that patient care that we give, we don't have time or room on how to improve it, because we're not going to go home after a long shift and figure out, hey, how can I improve these patient outcomes? No one's going to do that. No one's going to do that. So where can this change, or where can this initiative happen in nurses fostering and leading nursing care? It's going to happen in a hospital. And the only way to do that is on the job. And the only way to do it on the job is if you decrease the workload of the nurses that are trying to actually do these things, right? Because it's not going to happen at home. When have you went home and say, hey, I'm going to think of a better way to turn patients? You did it. The time you did think of it is when you were turning your patient at work. Yep. And that's the only time that's the only few minutes that you had time. And after that, you had to do something else. So how can you expect this drastic change to happen in nursing if you just overwork these nurses and they never have time to think about, hey, how can we innovate this? It's never going to change. And it sucks. But hopefully in the future.
To make a change in the nursing, it has to be nursing driven. It's no other way, because if somebody comes in a nice suit and tells you what to do, you're not going to do it. I just know that from my practice. But if it's you guys from your unit who get support from the administration and get that extra shift where you can just brainstorm and apply something new in your unit, or learn from somewhere what is that will help you to save resources and time and be more efficient, everybody will do it because you own it, right? Yeah. So that's very important too for all the hospital leaders to understand that you're not helping in changing anything if you come and give the directions. I think it should come from inside. And we did notice that at University of Chicago when we started to use lean methodology. I don't know if you heard about that, but it's very much used in actually in manufacturing cars. Toyota started to do that back in I don't know what years. So now it's coming to the hospitals. And what is interesting, back in 2010, we started to apply lean methodology at the University of Chicago. And like one of the main reasons why we're doing, because we wanted to stop wasting our talent. That means wasting your talent by running around and trying to find supplies or trying to find that Doppler that is usually somewhere in a surgical unit now, or also stop wasting supplies that you have to. So we did a lot of things, and all these things, all these changes were done by us, nurses, doctors, secretaries, respiratory therapists. So every time we were making a change, we had a team who had all these customers, I call, because we are customers there. We want to make sure that what we are doing, we're going to follow it and it works for us.
Yeah, that's a very good point. Yeah. Has to be nursing driven. Like, how is somebody gonna tell me to change what I'm doing that has never physically done what I'm doing? It's like telling a mechanic how to fix a car, and you're being a nurse. Mechanic's gonna be like, "What are you talking about?"
Yeah,
that's not how it works.
I'm kind of comparing this to the pressure injury issue. So in healthcare, if there's wounds, it's all hospital, right? Medicare's not going to pay for it. And we have all these fancy technologies trying to prevent skin breakdown, but you're creating so much stress in our workplace where maybe we're neglecting to turn the patient. Because why? We're trying to save this person's life. The last thing we're worried about is some skin breakdown, as crazy as it sounds. So maybe we're not having time to lotion the body or give a proper bath or fix the wrinkles and sheets, where we're lifting them really quickly and boosting them. It's creating friction shears. So we're trying to compensate by these fancy dressings and things like that, but you're never removing the problem, which is decreasing the stress from the healthcare worker to create or to implement and to work properly. So
right. And like from a nursing standpoint, it would be good to have like a skin team or a turning team available every 2 hours to turn your patient. But they don't have that. Yeah. What we do is, hey, you got a chart that you turn them every 2 hours. But that's like,
we do have it.
Yeah.
We had it at University of Chicago. I'm not sure if we still have it, but it was really great help because every 2 hours we had two strong lift team, members rounding all the ICUs. So they would come, and I'm not sure about the ER, probably not, but the ICUs for sure. So every 2 hours we would come to the unit, and it's not like they are turning by themselves, the patient, but the nurse definitely has to be there. But it was such a great help, because, sometimes you will need at least 4 or 5 people to turn one patient in some cases. So it did help us a lot. And then we also had a skincare committee that was run by the nurses who would do their rounds a few times a month, and they would go through all the units and they look at the patient's skin. And then also at the same time, they educate the nurses how to take care of those, usually stage 2 and 3 and 4 skin breakdowns. So that was very useful. So, I feel like I worked I was in a little bubble there because we had almost everything in our hospital. But now I'm realizing, especially when I started to spread awareness about helmets, that not all the hospitals the same, and not all the hospitals have all these resources. So this is why I feel like helmet, which is relatively cheap. So the helmet can cost about $150 to $250, but usually patient uses one helmet for the whole hospital stay. But other things that you can save with the helmet, it's like ventilator, intubation, complications, the same skin breakdowns, because now with the patient who is on non-invasive ventilation, we can shift their, body weight. We can do everything to prevent those skin breakdowns. Also, we can prone, we talk about proning a lot right now. And a lot of people don't realize how hard it is to prone an intubated patient.
Mm-hmm.
It takes the whole team to come and do that. With the helmet, patient is awake and alert, so the same like face mask. But with the helmet, it's very easy to prone the patient because of the interface. It's not going to press on anything on the face when patient is laying on his belly. And also you can put like a little towel or something soft inside the helmet so patient can just put his head on it. So yeah, that's another great feature that I forgot to mention earlier.
Awesome.
Yeah.
Is your team working on anything else, or yourself maybe, that's trying to improve healthcare, implement any changes? Because the way we talk about things, everything's flowing on this podcast so well. It seems very easy on how to solve the problems in the healthcare, right? But for some reason, there's so much complications, or I don't know, government's not listening. But yeah, is your team or yourself working on anything else to implement or change healthcare?
At this moment, my main focus is actually helmet-based ventilation, because I still, it is kind of critical time for the helmet, because if we're not going to use it in US, then I don't know if companies will be doing anything to keep these helmets in US, right? So, so what's going to happen if we don't have helmets? Well, we will see about 20-30%, more patients intubated. So and I think it's huge. If I can, prevent from that, prevent those intubations with helmet, why not? But I did a lot of work with creating the course. So I have online course, 4-hour course about helmet, non-invasive ventilation, and it has all the information for the nurses, for respiratory therapists, for physicians. So I feel like maybe that will make a change for not just in US, but also in other countries. And at this moment, this is my main focus. Another things that I do, definitely, I like healthcare, and I like medicine and also research. So I always look for some hacks, like we were talking about sleep last time, just a few minutes ago. Like, how do you, optimize your body, your health, your mental performance by doing less? So, if you find that hack where you can maybe sleep less, but have a good quality sleep and perform well next day, that's what I'm interested in. And I feel like if even when I worked in a hospital, I noticed that intermittent fasting, which usually just happens without even trying, when you work 12-hour shifts, that helped me also to perform very well and, stay on top of the things. So little things like that I'm also crazy about.
Yeah, we're all about learning how to hack your own body, and we intermittent fast. We've been doing that for pretty consistently for the last 3 years, I want to say, right? If not more. Yeah. Ever since we started working nights, I feel like we started intermittent fasting too. Yeah, and everyone's hack is a little bit different. What works for me doesn't necessarily is going to work for you, and what works for you not necessarily going to work for me. It's about learning how to hack your own body, how to optimize your life, and you have all these different diet trends, these workout routines that you have to do, but you just have to really sit down and figure out what works for you and not what everyone else is doing.
Yeah, exactly. So tracking data is also important here. So I use the Aura ring. You probably heard about it. So it monitors your sleep and your heart rate and heart rate variability, and it helps me to actually to find the things that will not help me. So for example, if I eat too late at night, I know that my sleep will be not best, and I will not be at my, I will not be performing at my best the next day. So, definitely alcohol is never good thing to do. So, and sometimes I even can see from that data that maybe I have to take it easy today. Like, I'm not going to go to the gym. I'm just going to rest or, do something easy like yoga. So yeah, that's another thing I'm so passionate about. And I'm wondering how can we make it, implement that in our workplaces. Because when I was a manager, if bringing donuts to the meetings was not my favorite thing to do. I just knew that a lot of people will show up if they have donuts.
They'll definitely show up more if you bring. They'll definitely show up more with donuts than a salad. Because you bring a salad, no one. You have
No.
people.
No, exactly. So I tried different things, and then still donuts was, the most popular. Definitely coffee, that always works. But yeah, it's I used a lot of hacks when I worked long shifts, and also when I was a patient care manager. So that helped me to stay, in a good shape and perform at my best.
And Aurika, where do people go to find you or find out more about this helmet-based ventilation?
So you can find me on Facebook, LinkedIn, but we have a website that is helmetbasedventilation.com. And there is a lot of articles, the story, and also that's where the courses are. Also, you can find some protocols, how to use helmets, latest studies, and some of them are so good. Like you can just read one study and you will know how the helmet works. It will cover everything that I talk in 4-hour training. Like one study that just came out this year was really good. I'm gonna mention that to you 1 second. Maybe you can put the link to it too.
Sure.
So it was the cpap bundle, where it has all the tricks and troubleshooting tips for the helmet interface. And then another one also by Greco and colleagues. So I will send that to you so you can post it.
Yeah, thank you. We could add it to the show notes. Anybody listening who wants to know more about it, they could read about it. And one last question we like to ask all of our guests. So if you had the opportunity to have a cup of coffee with anybody one last time, who would it be and why?
Very good question. I probably would like to have a coffee with myself 20 years ago.
Why is that?
Because now what I know about life and taking risks and putting myself out of the comfort zone, I know it's not going to kill you. So I would tell myself, back, when was it, 2000, let's say, that don't be afraid to take extra step. Put yourself sometimes in uncomfortable position, or get out of that comfort zone, because this is how you're going to grow. And I did this a lot, but I think I wish I could do even more. So that would be a nice thing to do.
Yeah.
And definitely, have a good cup of coffee.
It's a very good answer. No one ever said themselves.
Yeah.
So I love the thought process there.
It's really good advice for everybody. Like just take more risks. if you don't risk it, you're going to regret it at some point. So just try it.
Yeah, well, I have in when I make any decisions in my life, I usually ask myself, is that the right thing to do now? And is that going to hurt anyone? You always have to think about it. And if it's the right thing to do, you feel like it's also something that is true and I believe in it, you have to do it.
Mm-hmm.
And don't be afraid later to realize that maybe it was not the right idea, right thing to do. That's also very important. Then it gives you freedom to make that happen, right?
Mm-hmm.
When you don't put yourself in that box where you cannot acknowledge that you did something wrong or you were not correct. So that's what I did with helmet-based ventilation also. At the beginning, I was still learning, especially like different setups for the helmet. And I learned that some of them were not correct. So I would always contact my colleagues and put it on a website that, hey guys, this information was not correct. Make sure you do it correctly, right? So again, that's when you feel free.
Yeah, very true.
I love that. Aurika, thank you for being on the show and sharing your perspective about the helmet-based interventions. Maybe Peter and I will even pitch our unit that we work when we're travel nursing here. So yeah, thank you. You're a wealth of knowledge, and I hope that people realize the importance of this, and in general, the importance of being creative in their workplace and actually trying to see how we can improve healthcare, because like you mentioned, the empowerment and the change starts with us, and then we could trickle that into other aspects of healthcare.
Exactly. Thank you so much for having me. And I hope I helped a lot of people out there to learn something new. And again, don't think that helmet is a magic. It's a simple thing that is so easy to apply and learn. You just have to do it.
Yeah, thank you so much, Rika. Really appreciate your time.
Thank you.